Hello. Hello. Is that thing on? No. Okay. Well. Oh, but I didn't press the green button on this one. I pressed it on the other one. That's why. Hello. Oh, hi. Hey, everyone. Hope you're all enjoying your food, this fabulous food that we have tonight. I'm Jenni with Lung Cancer Initiative, and thank you all for being here. We are excited to be back in Charleston, and yeah, so I will start by telling you a little bit about Lung Cancer Initiative. This is our second year of this event. Raise your hand if you were here last year. Yay. Okay, a few of you, and then next year we'll even add more people to that. So I just want to give a brief introduction about Lung Cancer Initiative because we are more newly moving into South Carolina. I am based in Raleigh, North Carolina. Cheryl is in Seneca, South Carolina. So we're kind of spread out, but we are really trying to support more patients, researchers, providers in South Carolina. So that is our goal. And that is me. This is our agenda for the evening. Oh, and before I start, thank you to all of our sponsors. Merck is one of our education sponsors. We have Justin, who created our beautiful flowers and donated them. And Geraldine, where are you? I need glasses, I think. Okay. Yeah, yes, you do. Geraldine, you guys just wait for the pound cake. It is to die for. So thank you, Geraldine. Our exhibitors as well, thank you for all of you being here today. They're not just exhibitors, I consider them partners, and we can't do all of these events without them, so thank you all. So, Lung Cancer Initiative, really, I'd say that we are all about bringing hope and hope through connection. So, connecting patients, providers, researchers, advocates. We're a community. And so we're a community for anyone who has been impacted by lung cancer. And our mission really is to advance survivorship and provide support to those affected by lung cancer. And so those are survivors, but they're also caregivers and people who have lost someone to lung cancer. We want to support all of you. And you can see some of our values, our vision. So these are our programs. Most of our funding does go to research because we know that's the best way that we can impact a patient's life is through research. And in lung cancer, in the field of lung cancer, there have been so many research advances lately, and it's really exciting to see. And so we want to help be a part of that and support researchers getting into the field of lung cancer and hopefully staying in the field. We do a lot of education events like these where we educate the community. We also educate providers. We do awareness events, just anything to raise awareness, educate. I'm sure most of you here today know about lung cancer because you've been impacted, but there are so many people that really have no idea anything about lung cancer. The only thing they think of is smoking. And there is so much knowledge, so much education that the general public needs to know about lung cancer. We have a lot of work to do for sure. We also want to help support patients, and we support them through access to care, things like our gas card program, which we have opened in South Carolina now. So if you work with lung cancer patients or know a lung cancer patient, we don't want transportation to be a burden for them, so they can apply for a $50 gas card every 4 months, so they can get 3 a year. We have survivorship programs, which Cheryl will talk about later. And then community engagement. Like I was mentioning, we're just a big community. We're a network. It takes us all to really impact lung cancer and to help save lives. And so I feel like really we're a connector, an engager. I mentioned some of these as well, but we do have fundraising events. We have 5Ks, galas, golf tournaments, mostly in North Carolina. So we would love to get something going here in South Carolina. Most of these events are run by volunteers. So if you have a particular interest and want to help create one of these events, we would love to do that. Again, our community education, we have individual giving programs as well. And let me see. I want to mention too that really, if you're interested in getting involved in LCI in any way, you can reach out to Cheryl or I, and we can use your time, your talents, your effort in any way that you're willing to give. And so please let us know that, because it really does take all of us. And this is a brief history of LCI, and it's also in your bags, but it's just kind of cool to see where we've come from. We're celebrating 20 years this year, and I've been at LCI since 2013 when we officially became Lung Cancer Initiative. So it's really cool to see all the programs grow. And I remember then we broke off from a national organization, and we're like, okay, we're going to focus in North Carolina. All of our funds are going to stay here. We're going to support patients, researchers in North Carolina. And even at that time, our name was just Lung Cancer Initiative, but we were doing business as Lung Cancer Initiative of North Carolina, because we knew eventually we were going to drop the of North Carolina, which we have now officially. So it's just really exciting for me and others. I know some of our other friends that are here have known us for a long time, and it's exciting to see the growth and how far we've come, and to kind of see our goals and our dreams come true. And so you all are a part of that, coming to Charleston and kind of seeing that come to fruition. Here's some of our research numbers. Like I said, this is where most of our funding does go to, and we've funded a lot of research, and we're very proud of that. We've opened our research funding to South Carolina now, and so we're excited to get involved in research here locally and be able to support the researchers and providers here. We also are investing some effort in screening, because we know that that is an area that we can really have a great impact. I think it's about 18% of patients in North Carolina that are eligible to get screened are getting screened. So only 18%. There is a smoking history that you have to get screened. And so that's a whole nother story, because we know you don't have to smoke to get lung cancer. But there is a lot of need in the area of screening. And so we're trying to get out in communities, raise awareness about that, work with local screening centers, partners, mobile units, however we can, to get those that are eligible for screening screened. And now, you were going to take a picture. Cheryl Lecroy, our survivor liaison. So that's the answer.
Mm-hmm.
I think that's it.
Okay, thanks. Thank you. Yay, Jenni. I have had the best time working with Danai for the last 2 years with Lung Cancer Initiative. There is so much heart and soul in this organization, and I'm just really pleased to be part of it. I am the survivor liaison for Lung Cancer Initiative, have been for 2 years. Prior to that, I worked for about 12 years in designing wellness programs for lung cancer survivors and other survivors, and we work on integrative modalities, complementary care to your treatment. And I'm just so excited to be able to expand this and be part of the lung cancer community. So before I get started, I'd love to just recognize the survivors we have in the room. Could I ask you guys to stand? Our rock stars. It is so good to see you guys here. Truly the wind beneath my wings, and the reason that I continue to love supporting you and being part of this. This is a little snapshot of the funnel and how we serve lung cancer survivors. So when a survivor is introduced to Lung Cancer Initiative, whether that's through their physician, or whether they find us by their own search, or whether it's through a nurse navigator, they get connected with me. And we not only serve the survivor, we also serve the family members and the children. So we're doing more and more with programming that will support the whole family. And then you'll see that, once I kind of assess and connect with survivors, we determine what kind of support we have for them. Are they interested in, something like a deeper connection? Are they just need-based? We know that survivors don't all need the same thing, and we meet survivors exactly where they are. And sometimes, a survivor might come to us with one need, and then a few months later, really want to get connected in a deeper way. So it's really important to serve survivors where they are. And I always will say, I believe it's important to serve our survivors. And then sometimes our survivors will turn around and serve others through this community, and it's beautiful to be part of it. I mean, I see 3 survivors who are serving others in this room, so thank you so much. But connection is a big part of our community. Connection, we build programs that open up community and hope, and through that, it just keeps this community really robust. Our survivorship and patient support, this shows a little bit about how much and the numbers. And, survivorship was not a big part of LCI until about 10 years ago, when they brought us on to do some wellness retreats and other things, because survivorship wasn't really something we talked about in lung cancer prior to that very much. And so we've watched it change. We've watched folks survive. We've watched the work that you've done and made a difference and an impact in how folks are surviving. So we're here to support them in however it serves. Our patient emergency fund, last year we served 159 patients. Gas cards, we served 455 patients. For deeper connections, our community engagement, our survivor wellness retreat, we have between 8 and 12 folks that come to our survivor retreat, and then even deeper connections, about 146. So, while those numbers have grown, we all know there's work to be done, because those numbers, we know how many survivors there are of lung cancer, right? So together we're spreading the news and trying to serve more survivors. Our survivor wellness retreat, this is something that we host once a year, and it's actually coming up in September. It's available for your patients. It's available to your community, your network. It is the integrative, we're taking the survivor out of the clinic and putting them back into nature, and going back to what it is that, is so important before the diagnosis, during the diagnosis. So we have 2 beautiful survivors that have experienced our wellness retreat. Any questions that you have about that? Certainly. I'm sure Debbie or Sharon would be glad to share information with you. And I can get more information to you so that you can share it with your patients as well. And so with that, I would love to welcome a survivor that I have just so much respect for and have come to love very much through knowing Debbie. So Debbie is going to share her story with us. Debi Fitzgerald.
Good evening, everyone. Thanks for having me. Thanks to LCI, and thank you so much for sharing your story. I've got some slides for some of the research that I've been focusing on, and I'll hope to make them digestible for you all. These are some of the relevant disclosures for funding that I've gotten. I wanted to start off with it kind of in 2 sections. This is a patient who presented to me to clinic for a nodule found on her x-ray. It's in the bottom left here. We have no, let me see if I can put on a pointer, pin and pointer. Yeah, does that work over here? This little hazy area here, this is in the middle of the lung, back on the table, chest up top. It's like you're the lady in the magic show, I say. You're getting cut across side to side. And this was found on an x-ray for cough. This patient had a PET scan, and PET scans are activity scans. In this area, it doesn't have much activity at all. If there was activity, you'd see bright yellow or at least some red. Basically no activity at all. We watched this area for about 4 months, and it had essentially no change. 10 months later, this patient presented to the emergency room for shortness of breath, feeling unwell, coughing, got antibiotics and steroids, had no improvement, and then over another month with worsening symptoms, finally got a CAT scan of their chest. And these gray areas in the middle of the chest are areas where lymph nodes live. Lymph nodes are an area that cancer often spreads to. This was evaluated with an activity scan, a PET scan, and you can see these bright yellow areas in the middle. And this is this fluid compartment, like a Ziploc bag of fluid next to the lung that's now newly present. And this patient ended up having a bronchoscopy and was diagnosed with small cell lung cancer. Lung cancer being kind of two big buckets, small cell and non-small cell. So these are the two, we kind of lump these into localized to the chest, limited on the left, an extensive stage spread outside of the lung on the right. We treat non-small cell lung cancer slightly different. And this is a trial published back in 2014 showing how quickly patients are no longer with us with this disease, depending on whether they got no therapy at all in red, or more and more chemotherapy in the two blue lines. And you can see this is a pretty aggressive disease. When it hasn't left the chest, average survival is probably 6 months to a year. When it's left the chest, survival is probably more like 6 months. And it kind of depends on whether you can get or tolerate treatment for it. This has had a big change in the last 40 years. Just finally, in the last 5 years, we've got new medications. No change for 40 years, and now finally new medications and new hope. That was the dismal part. I'm supposed to be bringing in hope, and so I will try to do so. This is just trial results. The point to know is that the yellow line means that more people are alive than the people who were in the blue line, and the people in the yellow line got immunotherapy. Okay, this is in people who it hasn't left the chest. They got chemotherapy, radiation, and immunotherapy. And it doesn't seem like a dramatic result. The median or middle time, 33 months versus 56 months. But again, the first improvements seen in 4 decades. This immunotherapy is an important new drug, and I won't spend a lot of time here, but the immune system in blue is constantly attacking cancer cells, hopefully. And one way that cancer cells escape is by putting out a little stop sign, this PD-L1 purple stop sign saying, no, don't worry about me. I'm just normal lung tissue, for instance. And so this infusion in green is a little antibody that blocks that stop sign and allows the immune system to kill cancer. And this is overly simplified, but gets to the point. And this similar effect is seen in patients with cancer that's left their chest with small cell, so extensive stage, metastatic stage, small cell lung cancer. The blue line better than the red line, and this blue line really extending for many years. It's a small proportion of patients that are still alive at 5 years, but still some patients are, where in the past it was far less. And then there's new medications. This is a second line therapy. It's not quite immune therapy, but it does interact with the immune system, so I guess you could call it that. But drugs like tarlatamab, this is after you've progressed on the previous therapies, improve survival on the next line. And there's even more first-line therapies approved in just the recent times, with more complicated names that we need to get into. But part of my focus is on lung doctors, pulmonologists. What do they know? So the first approval for immunotherapy in small cell in the first-line setting, I think, was in 2019, and this survey was last year. And we asked people, how familiar are you with immunotherapy in this cancer? And you can see about half. This is split up into limited being blue and red being extensive stage. About half of pulmonologists really don't know this therapy exists. So it's the first advance in 40 years, and most lung doctors, often a first contact for patients with lung cancer, don't even know that the developments have occurred. We asked, why might patients not get referred for treatment? They universally reported and by the way, this is an unpublished survey. It's hopefully submitted in the next few weeks, but this is not peer-reviewed data as of yet. Most people who were, almost all patients were referred by about 400 pulmonologists answering the survey. But we asked, well, what if they didn't accept the referral? What was the reason? And it was this most common reason was patient refused referral. They didn't want to be treated for some reason. A few other highlights: maybe patient didn't have the family support or transportation or otherwise. And then a small percentage, maybe 20%, that you were concerned the patient was too elderly or had too many other medical problems that would limit treatment. And then we asked a couple questions about pulmonologists. We asked several, but these are two highlights. We asked them, how often or how much do you agree with the treatment for this cancer being worse than the disease itself? And in blue, about 63% either didn't agree or disagree or agreed that maybe the treatment for small cell is worse than the disease. And in the second question, we asked, would you agree or disagree with it? It's mostly up to luck if a patient with small cell lung cancer survives more than a year or two. And about 40% agreed or was neutral on that question. Up to luck, just luck. And so it gets back to the phone call that you mentioned. When these patients receive these phone calls from a pulmonologist about a new diagnosis, small cell is a very aggressive cancer, and for the last 40 years, pulmonologists and other doctors have seen time and again very poor survival. But with new treatment advances, we have to make sure that our pulmonary colleagues, primary care doctors, and others know about these advances, so that if someone is maybe thinking about not taking that referral, that at least they're armed with the knowledge of the current treatments to make sure that they consider. That's something I certainly always do for my oncology colleagues, is you don't have to get therapy, but please see an oncologist. Miriam Alexander, John Rangel, Chris Rangel, my colleagues in oncology, make that decision with them, not with me. So this patient, 2 years after presentation, receiving chemotherapy and immunotherapy, you can see that hazy spot down here is still the same as 2 years ago, hasn't changed a bit. And those spots that were in the middle of the chest, these kind of intermediate gray spots, are gone. She did have one new spot in the brain pop up. This was the first time outside of the chest, and it was treated with a single dose of radiation, and at this time has no evidence of disease. So for small cell, with some of these results that I'm getting to learn and to review, we have the first advances in very recent times in the first 40 years. These advances are not biomarker driven, like we'll talk about in the second part of this talk, and that patients and clinicians have to know that some of these options are there to help guide appropriate referral and combat nihilism and to have hope. The second section, I want to talk about some of the recent research and findings I've had regarding non-small cell lung cancer. So non-small cell adenocarcinoma, squamous cell, those are all synonyms. This is a survival curve, so how many people are alive across the x-axis years here. And you can see this is for stage 4, so this is metastatic or stage 4 lung cancer. This is older data from 1990 to 2000. And you can see many patients are dead before the first year, unfortunately, is out, and very few are surviving 5 years. As your stage is less, the less spread you have, the longer people tend to live. This is an old study from the 2000s where people were comparing chemotherapy plus supportive care in blue to just supportive care alone in a yellow. And you can see that dotted line is median survival. Probability of survival at 50%, half people in this trial alive. And the difference at that median point is only about 3 months. So at that time, chemotherapy maybe gave you a few extra months and maybe arguably gave you some quality of life and maybe also hurt that quality of life depending on your reaction. This is the next patient's images. They presented with progressive respiratory symptoms. This is their main lung mass that's highlighted on this activity scan. These other spots are lymph nodes. And then these small dots are presumed cancer spread areas, too small to light up on this activity scan. This patient underwent a bronchoscopy, and biomarker testing was ordered very quickly. Both on the tissue, we have to do this extra sequencing and testing of the tissue, and on the bloodstream. Both tests returned with a mutation in the EGFR gene exon 19. This patient, just to get to the chase, was treated with an EGFR tyrosine kinase inhibitor, and this shows this original area here shrinking and scarring down with no evidence of anything growing at this time, remains on therapy and living their life. This is the trial that shows that this new generation EGFR tyrosine kinase inhibitor was better than its comparator, so the blue better than the red. But if you overlay the earlier clinical trial, it's not a fair thing. It's not like we're really comparing the two, but this was the old trial for chemotherapy. So really the difference is in EGFR therapy, a targeted type therapy compared to chemotherapy, the outlook is far superior. And in this trial, patients' median survival was over 3 years rather than just maybe 6 months. And for pulmonologists, many of the pulmonary fellows I gave a similar talk to didn't know what this reference was, but for lung doctors, many people are asking how many needle pokes does it take to get biomarker testing, and it's a question that I'm very interested in. But yeah, all the kids these days in training, medical training, have no clue what that reference was. On the left is a survey that we published in 2021 asking pulmonologists how many needle sticks they do of a lymph node or a lung mass. And most said 3 to 4, but there was a 30% little group here who did far more than 3 to 4, trying to get more and more tissue. On the right, this is not my data, but it's a review of multiple studies, how many passes. And so you can see as you approach 6 passes, you approach 90 or so percent of getting the answer. But it's way more complicated than that, and I'm going to try to convince my pulmonary colleagues that that's not the right way to think about it, in that at every step of the way, from biopsy to testing, makes a difference. This is a depiction kind of a lymph node. Sometimes you got a lot of cells. Sometimes it's completely replaced by cancer cells. If you stick the one with less cancer cells, you're going to have to stick it a lot more to get an answer. You'll see pulmonologists, if you're watching the new procedures, they'll hold the little specimen come up to the light looking for little things floating in their sample to see if there's enough. But you don't know if those little spots are little specks of blood clot, if they're chunks of tissue, chunks of cancer. You just don't get to know. There's a lot of things that you can put these cells in, these different solutions, and some of them actually affect your ability to do biomarker testing. Our pathologists love when we create slides, little bits of tissue on a slide smeared across, because they can be very valuable. These are one of my patient slides. These little purple marks, I should have exploded these a little bit bigger here, are areas, groups of cancer cells. You can see this one has more, this one only has one. And then what happens to that cup? That cup gets spun down to a little tiny pellet, put in wax, cut open, and put on a slide, and you just don't know what's in that cup. Sometimes you get so little that they try to cut it and they can't really cut it, and you get nothing. And sometimes it's plenty of tissue for any and all testing that needs to be done. And then what do you send it for? This is too much. I know it's too much. I haven't had time to fix it. But there's a bunch of different tests you can run. They need different amounts of tissue, different amounts of cancer cells, and they all don't work the same. And so in the end, you've got a pathologist who's looking at a sample who might say, no, I don't think this is enough. But you always have to know, does that pathologist know what you're sending it for or not? Because if you're sending it to a commercial laboratory that requires big chunks of tissues, you may not be able to get biomarker testing completed. But if you're sending it for a smaller focus panel, something that we have available at MUSC, where our pathologist will even scrape a cellular slide to perform this testing, then maybe it is adequate. And so we'll often call our molecular pathologists and say, hey, they said there wasn't enough, but would you review the sample for us? And they'll say, yeah, you maybe not get every little thing you want, or maybe there's a chance you get it all. Let's try. And so there's this final step of someone has to adjudicate, is there enough or not? And sometimes they may not know. Finally, there should be a sense of urgency. I like that you had that to be a piece of your message. This was in a collaboration. This is also unpublished data, accepted but unpublished. A collaboration with one of the commercial testing companies looking at time from biopsy to completion of results being available from 2018 to 2024, 62,000 lung cancer samples, the average time going from 36 days to 27 days. There's a lot of variability. This needs to be a little bit bigger, but we took the fastest 40, or the first quintile, so the fastest 40 and the slowest 40, and they were pretty different. A difference of 20 days on average versus 40 days on average to get your test results. And then keep in mind how quickly some patients are expiring with stage 4 cancer and how urgent this is needed before their first treatment. This is time from biopsy to order, about 14 days. These big red bars mean there's a ton of variability across the sites, and no improvement from 2018 to 2024. This was our shipping and handling time. Once you order it, how long does it take it to get to the company? About 4 to 5 days. Find it, package it up, send it to the company, have them receive it. And then the only improvement, the driver of the improvement, was how fast the company could run the sample. They went from about 13 days or 2 weeks down to about 1 week. So once they got it, they ran with it as quickly as possible. And the unfortunate thing is this time to order, and this is an area of my intense focus because most people who have a new diagnosis of lung cancer haven't met an oncologist yet. They have to be referred to one. And so pulmonologists very commonly diagnose lung cancer, pathologists see all the samples. How do we coordinate the ordering of biomarker testing to the point before the medical oncologist, but in collaboration with them? That is an area of my intense focus, and basically the grant I have from the American Cancer Society to look at that issue. So I only covered the one metastatic lung cancer case, but these therapies are gaining indications across most stages of lung cancer now. So this testing is really relevant for almost all new diagnoses. Communication with the medical oncologist, pathologist, pulmonologist about we need the tissue, how do we handle the tissue, where is the tissue going, where do we send this sample for the testing, and of course, time is critical and this information is urgent. Have to thank my primary mentor, Dr. Gerard Silvestri, and the American Cancer Society, and thanks again for LCI inviting me. Everyone in the back there, my clinical colleagues in the back, thank you for your help over the years. That's all.
On top of here, am I gonna like ruin this?
Make your whole thing go nuts.
Oh. Good evening, everybody. I'm Debbie. I'm basically your entertainment for the next 30 minutes, so I apologize for that. I want to start out first by thanking Lung Cancer Initiative for having this event, especially in the Charleston area. And I would like to give a very heartfelt thank you to Cheryl Lecroy, who is always eager to help. And Cheryl, you just have helped me more than you'll ever know, so thank you so much. A delightful, unfortunate woman. That is how my oncologist describes me in the first clinical notes he ever wrote in my patient portal when I first met him. Mrs. Fitzgerald is a delightful, unfortunate woman. And I remember the first time I read it and I thought, well, he's got the delightful part down cold, but unfortunate? It seemed an odd word to describe me because my entire life, I've never thought of myself as unfortunate, quite the opposite. My husband Tim and I, we are both from Long Island, New York, and 1 week from tonight, we will be celebrating our 38th wedding anniversary. So now you know New York allows 10-year-olds to get married, right? But we don't just have a 38-year-old marriage. We have an amazing marriage, friendship, relationship. Everything that I have been through since my diagnosis, my husband has gone through, but even harder than I have. And I know that if the sky opened up and said, you can switch places with her, he would do it in a heartbeat with no questions asked. We have 3 amazing children, and I don't say they're amazing just because they're mine. They are simply just wonderful human beings. We're a very close family, and they too have been instrumental in getting me through this. When you get diagnosed, you're not the only person that gets diagnosed. Your whole family gets diagnosed. Your really close friends get diagnosed too. And my family has been nothing but supportive and loving. I've spent most of my life, my adult life, as a fitness professional. I'm a group fitness instructor. I absolutely love teaching classes. And I'm also a personal trainer with a specialty in Pilates. So I'm used to being on the other side of this equation, where I'm the person who helps people who are in pain or injured or after surgery, or people who just want to feel better about themselves. And I've always loved that about my job. So when this diagnosis first happened, I was very angry because I've always kept myself very fit, very healthy. I'm always I'll have the salad, even though I really want the cheeseburger type of person. So I kind of felt like my life was a joke and that everything that I believed in was wrong. But now I realize that being fit has really benefited me, especially when I think about what I have been through in the last 16 months and what I'm going to go through pretty much forever. So I continue to keep my fitness as a priority, as it's something I can control, it's something positive, and I know it will give me a better outcome. So we moved to Charleston about 7 years ago, but by the end of 2023, I decided to ramp down my work schedule, and I stepped down as Director of Wellness and Fitness at the YMCA. I just wanted to teach a few classes a week, have a few clients, and actually have time. So 2024 was pretty amazing. Daily, I would think to myself just how great life was right now. My schedule was perfect. My husband had more time than he used to. And we got to do fun things like walk the Ravenel or take the dogs downtown and go split some cake at Carmela's, which I highly recommend. I thought we finally started the next chapter of our lives, and this is going to be great. But then at the end of 2024, about a week or so before Thanksgiving, I found a lump in my left breast. I didn't panic. I thought it's probably a cyst. It was the size of a little gourmet jelly bean, but it was definitely there. I called the doctor the next day, but by the time I got to see the doctor, because it was the holidays and then I had got sent for the wrong mammogram, by the time I actually had a biopsy on my breast, it was the very beginning of 2025. It was the first week on a Thursday, but I still wasn't worried. The next day, Friday afternoon, because everything happens on a Friday or a weekend or a holiday, I was at home getting ready to go to a client's, and a message popped up on my phone informing me that I had results from my chart. So I opened up my phone thinking it's going to be nothing. And I read this report and I see things like invasive ductal carcinoma and something called a triple negative breast cancer. And I remember the word aggressive popping out at me. And I was stunned, and I did what I'm sure a lot of people do. I made sure it was my name and my birth date and, the right day of the biopsy, and then I shut the whole thing down. And then I opened it and reread it, and I did that about 10 times, hoping another report was going to show up. And then my phone rang, and it was a doctor who I had never met before in my life. And he said to me, "I'm so sorry. You have breast cancer, and you need to call your primary care doctor, who will refer you to a breast surgeon and an oncologist. Do you have any questions?" I had about 1 million questions, but the only thing I could get out of my mouth was, And we hung up, and that call lasted about 2 minutes. I did call my primary doctor several times, I told the receptionist I needed to speak with her, that I had just been diagnosed with cancer. And while the receptionist did give me the name and number of a breast surgeon and oncologist that they referred people to, 5 o'clock came around and I never got a phone call back from my doctor. I called the breast surgeon's office several times too, because the earliest they could see me was in a week. And I found that a little unbearable when I had just been diagnosed. There seemed to be no urgency. Nobody wanted to talk to me who could actually give me information. At this point, I hope you understand not only the fear, but the frustration I felt. Like I was patient 7,896 and nobody cared about me. Why was there no urgency? I understand the medical community can be overwhelmed, but nobody should ever find out that they have cancer through an app or a portal. Nobody should hear for the first time that they have cancer from a doctor who has never seen their face or knows anything about them other than a report or an image. It's cold, it's cruel. My husband and I were just lost that weekend. But the unbearable week passed, and we went to the breast surgeons, and I remember there was a white plastic Christmas tree on the reception desk, decorated with pink ribbons all over it. And there were posters everywhere about early detection and self-breast exams. The breast surgeon did make us feel better. He was a very come to Papa, I got this, you're going to be fine. Your lymph nodes look good, this is solvable. And he hugged me. He told me I was going to have surgery, chemotherapy, and radiation to cancel whatever plans I had for the year, but at the end of it, I was going to be fine. In the office with him was a breast navigator who gave me her card, and she explained how I was going to feel through chemo. She gave me a loose leaf binder that was about that thick, with every resource in it available to me because I was just diagnosed with breast cancer. I could get wigs and scarves and hats or bras, massages, facials. There were support groups in person, online, and there were phone numbers in the back that I could call anytime for just about any question that I had. I was told many, yay you, early detection, as an MRI showed my lymph nodes were indeed clear. So my husband and I wrapped our heads around the fact that I had stage 1 breast cancer, and we told our children and thought, okay, well, 2025 is going to suck. But by the time I'm taking my Thanksgiving turkey out of the oven, I'm going to be fine, and this is all going to be behind me. And then I met my oncologist. He explained all about breast cancer to us and what was going to be happening to me and why. But then he told me he was making an appointment for me to go to something called staging, basically a CAT scan to check the rest of me, and that the other doctors were going to tell me I didn't need to do this. But he said, if you were my wife, I would tell you to go, so I want you to go. And he asked the nurse in the office to make the appointment for me sooner rather than later, is what he told her. He also made her make appointments for a bone scan, a brain MRI, and another appointment with him after all of those. He said to me that if the staging was okay, that we would cancel the other tests and he would see me after my breast surgery. But the way he looked at me, I just knew something was off. I now know that he did not like the way the images of the breast tumor looked and had been having a little back and forth with the radiologist and the breast surgeon about it. Because apparently when you have a tumor in your breast and your lymph nodes are clear, you are stage 1 breast cancer and there's no need to do any further testing. But he did not like the way my images looked. And I cannot thank him enough, because if it wasn't for him, I would have had surgery and I would have had chemotherapy for a cancer that I did not have, and I probably would not be here with all of you this evening. I did go for that staging, obviously, and of course it was a Saturday night when I get another email from MyChart saying my test results are in. And I looked at it because I hadn't learned my lesson yet. This time I saw things like lung mass and the word metastasis, and I don't think I really saw much after that. You never in your entire lives could believe that a woman could wish so hard for stage 1 breast cancer and a good case of pneumonia. There were many other tests and procedures in the weeks that followed. One day alone, I had 3 procedures in a row. I had a pleurex drain put in because my lung chamber was filling up with fluid. I had had a thoracentesis. I had a lung biopsy, and I had a port put in because we knew I was going to be getting chemotherapy. It was quite a morning. Eventually, the biopsy on my lung and having the lab rerun tests on the biopsy of my breast led to my oncologist, Dr. Balil, calling me one evening and saying, "Look, love, I'm so sorry, it's your lung. It's not breast cancer. You have lung cancer that went to your breast." And he kept telling me that there was treatment, that he had treatment for me. Now, the chances of lung cancer going to your breast are 0.2 to 0.27%, so very, very rare. But I still had one other appointment on the books with a breast surgeon, and it was very different from the first one. This one was brief. The surgeon was clearly uncomfortable because this wasn't something that he could fix. He told me that nobody was telling me that I had 6 months to live yet, and that I was now the oncologist's, and he left the office. The breast navigator left right after him, and all of those resources in that book she had given me, those all left too, all of it. It sounds funny, but I actually felt like I had been demoted. I learned early on that there was a very big difference when going from breast cancer to lung cancer. Please understand, I'm not diminishing breast cancer in any way. They have just done an excellent job of making society aware of it and getting support. But if breast cancer was the darling of the cancers, lung cancer was definitely the redheaded stepchild. There are no lung navigators with giant books of resources. In general, society views lung cancer differently. I have met women in the last year who won't tell anybody that they have lung cancer because they are afraid of the reactions that they will get. I've had people say to me, "I didn't know you smoked." Well, I never smoked. I was the healthiest person in the universe, but does it really matter at this point? I also felt very much like a failure because of all of those "yay you" early detection. That was gone. I mean, I'm a personal trainer. I have really good body awareness, so how did I not know that I had this tumor? There's no self-examination you can do on your lung. And apparently, you can't feel something that's 4 millimeters in the center of your giant lung. And if you don't smoke and you are symptomless like I was, nobody ever thinks that you might possibly have lung cancer. This is something, as a society, we need to change. When we saw my oncologist for the first time after the correct diagnosis of lung cancer, my middle daughter met us there, and she thanked him for saving my life and through tears asked for a second opinion. Dr. Balil immediately was, of course, who wouldn't? And he asked her if the lung oncologist from MUSC would be okay with her, and she said yes. He called that doctor right there in front of us and made an appointment for me with her, Dr. Alexander, for 2 days later. He then told us he was still awaiting more information from my biopsies. He was hoping I had a biomarker where you can better target the cancer, which is the future right now for cancer. But he wanted to start chemo ASAP because my breast tumor was getting big fast. When I did meet with Dr. Alexander, she too hoped I had one of these biomarkers. She told me she would be staying on my case with Dr. Balil, and I could call or see her anytime. She also sent samples from both my biopsies to a second lab to double check everything, and I felt confident I had good eyes on me. When writing this presentation, I realized how much I went through last year, and I honestly don't know how my husband, my children, and I did it. Basically, I had 12 rounds of chemo with a little hiccup on one of them because eventually your body gets tired of certain chemo drugs. Wasn't fun. The pleurex drain was removed surgically in April, but unfortunately, I wound up having cancer seeded in me from that procedure, another rarity. We did not discover that until August of 2025 when, for the last time, I looked at the results of my scan in a patient portal. I had cancer all around my side and a tumor that soon grew under my rib, on my rib, under my breast, and it hurt. 15 rounds of radiation on top of chemotherapy followed. My doctor was trying hard to get me out of pain and this new growth under control, especially because my husband had planned a family vacation to Greece that I'd always wanted to do someday when we had money. And we were leaving in a month. My doctor is very in favor of me living my life, and he was thrilled that we were going. He sent me to Greece with every medication under the sun, with all of my paperwork and his personal numbers just in case. He wanted to make sure I was well prepared and could enjoy this trip with my family, which I did. By the time I got back from vacation, Doctors Balil and Alexander decided I really needed to be on an EGFR targeted therapy. I had tried one in March, but I had a very bad reaction to it and had to discontinue after 8 days. I had also tried immunotherapy that summer, but it was not effective. So while I have an EGFR, which is fairly common, I have a mutation that is ultra rare, under 1% of people. So my doctors weren't sure which treatment would actually work on me or not. Knowing I'd lived in Connecticut, they knew that going to a doctor at Yale would be easier for me than some other places, especially if I had to stay for any length of time. So they gave me the name and number of an amazing EGFR specialist up at Yale. Good friends picked me up at the airport and insisted I stay with them. My son took me to Yale and stayed with me during my appointment. The doctors there told me there is no research saying these treatments will not work on you. There is just no research saying that they will, because you've never been represented in a cohort. But they agreed with my doctors in South Carolina that we needed to try targeted therapy. They told me they were on my team now and I could call them anytime and see them anytime, and so could my doctors in South Carolina. They ran all of my biopsy information into their database at Yale and a few days later called me and my doctor and discussed what their database told them was going to be the most effective treatment on me. They wanted to make sure that my doctor was comfortable with that, since he was the one who actually saw me and had to administer it. I love that none of this was, we are dictating this to you. Instead, it was a huge collaboration between my main oncologist, Dr. Balil, Dr. Alexander at MUSC, and now the team up at Yale. These doctors discussed and figured out what was going to work best for me and listened to me as well. And I'm so incredibly thankful for that. Dr. Balil, I know, will do anything as long as it's in my best interest, and that's how it should be. It lets me trust him and the treatment he sets for me. He tells me all the time, leave your cancer here and go home to your handsome husband and your family, and go to the symphony, and go to dinner. Plan your trip to Italy this year and enjoy yourself. Enjoy life, because that is how you beat cancer. While that's easier said than done, I can do it because I trust that what he is doing is correct. Plus, I have joined groups like LCI, and I hear what other survivors have been through, what their treatments are, their testing. I know that everything that should be being done for me is. So this past January, almost 1 year to the date since my breast biopsy, I started on amivantamab. I was apprehensive to start it, but my doctor explained things and walked me through it beautifully and was very prepared as to minimize all of the side effects. So far, I'm doing well, and on my PET scan in February, it showed that all of my tumors are gone. The one that was planted in me, the original one in my lung, both gone. And chemo last spring had taken care of the one I had found in my breast. My doctor's office is now working hard to try to get another drug that goes with the AMI called lazertinib, sometimes called Lecroy, because my insurance company refuses to pay for it, despite all 3 sets of doctors wanting me on it. So we are appealing to the pharmaceutical company, J&J, to try to see if they could give it to me, and I'm hoping for a positive outcome. When I was first diagnosed correctly with lung cancer, I looked online, but I could not find any support groups in my area. I found Lung Cancer Initiative by luck when searching online and wound up emailing and then having a conversation with Cheryl Lecroy, who I instantly felt I had known for years. While LCI is mostly in North Carolina, she told me about their virtual luncheons that I could attend and that they do some events in South Carolina and hoped to do more, like tonight. She then invited me to a survivor event dinner up in Raleigh-Durham with my husband, even got us a hotel room since it was a 4-hour drive. We went and walked into a restaurant of people we had never met before, and when we left, it was as if we had known these people forever. When my husband and I went back to our hotel, we literally wept because we had just met people who were lung cancer survivors of 2 years, of 5 years, 7 years, 15 years. A woman who spoke that night had had a lung removed over 20 years ago, and there she was, thriving. We cried because finally we found hope, and that's what Cheryl and everyone else at LCI is about. I also attended a 3-day retreat with them last fall. Not usually my thing, but I was very glad I went as I met people and experienced things, all positive, that I will never forget. And it was at an LCI virtual support meeting that I learned to appeal to the pharmaceutical company about the drug instead of my insurance. So many people, old friends, new friends, neighbors, my beautiful family, even students from years ago in Connecticut. I have had so many people who have offered help and made kind gestures, cards filled with good wishes, blankets and books of hope to take to chemo dropped off on my front porch, dinners made by friends for those yucky chemo days, offers to live with friends in Connecticut if I ever needed to stay at Yale or MSK, texts and calls of support. I have had such an outpouring of love from so many this past year. I have doctors who I trust and my main oncologist who encourages me to live my life and let him take the worry of the cancer. I have my warriors at LCI who understand exactly what I am going through and offer help. I have my husband, my rock, and my children, my joy. And in 2 months, I will also have my first grandchild, which makes me so happy, my heart hurts. And while I have slipped into the under 1% chance of this happening to you door several times with my cancer, I intend to slip under another one where I'm up here telling you all about my grandson's graduation from college. So with all of these amazing people in my life, what I really am is a delightful, very lucky woman. I just have had something unfortunate happen to me, but I'm getting through it. So cheers to more research, more treatments, better outcomes, and to all of you. Thanks so much for listening.
Thank you so much for having me. Some tough acts to follow here. And Debbie really teed me up for part of this, so I can't wait to show you all of this. All right, so I am going to talk today about hope in lung cancer, which just so happens to be a topic I know an obscene amount about because I did my dissertation on it. So the first time that I met Cheryl, I don't know how we got on this topic, and she started talking about hope, and I was like, talking about the theory, and I was like, actually, I know a lot about this. And she was like, oh my gosh, we're gonna have to have you come talk about this. So now is my time. And thank you for the kind introduction. Nice to see so many of my MUSC colleagues here. No disclosures to report. And I am a person who practices what I preach. If you've seen me talk before, I do this every time. We're gonna all take a little mindful minute together. So you've been sitting for a while, so if you would like to stand up, you are welcome to. If not, I would invite you to just sit up really straight in your chair, plant your feet firmly on the ground. I see some standers, I love it. Same thing, so if you're standing, you wanna kind of have an open posture, right? Arms nice and open by your sides. If you're sitting, hands can be resting down or palms facing up. And you can either close your eyes or just have a nice softened downward gaze. And we're gonna just spend 30 seconds focusing on a sensation of the breath. So you can focus on the sensation of the temperature of the air going in and out of your nose or your mouth, or you can focus on the sensation of breath rising and falling in your belly. If your mind wanders, which it will, that is fine. Just bring it back to the breath. All right, welcome back. Thank you for indulging me. This always helps me get a little talk jitters out, and it's a nice kind of introduction shift in topic, hopefully. All right, so we're going to talk about hope. First, here's a little outline for our plan today. We're going to talk about what hope is. I'm going to introduce you to a theory about hope. I'm going to tell you why hope and optimism are not the same thing, even though we sometimes use them interchangeably. Then I'm going to show you some research, the research that I talked about from my dissertation, looking at specifically at hope in patients with advanced lung cancer. And then I want to leave you with a couple of practical strategies for how you can foster hope in the context of lung cancer. All right, so we throw around the word hope all the time in cancer. I actually walked downstairs this morning because I had noticed this before, but I had not taken a picture. This is actually on the wall at Hollings Cancer Center. It's this Emily Dickinson quote about hope. And then on the right, this was actually a plaque at Moffitt Cancer Center where I did my dissertation research that also includes the word hope. And these are like lovely, beautiful quotes, but unfortunately I'm a researcher and I can't study these like soft constructs. So we have to go to Merriam-Webster here, who says that hope is a desire accompanied by expectation of obtaining what is desired, or a belief that it is attainable. So you want something to happen, or maybe you want something not to happen, and you believe that that is possible. So Rick Snyder was a researcher back in the 70s, 80s, and in the 1980s, he was on his sabbatical from the University of Kansas, and he became really interested in kind of establishing a formal definition of hope. And so he interviewed people that he identified, I don't know how, as hopeful, and he asked them to describe how they thought about their lives. And what he found is that there were three kind of common attributes to the descriptions that people gave. So the first thing was goals, the what. So he found that these people all had something or some things to be hopeful for. He also found that all of these people had what he called agency thinking. This is kind of the motivation, the capacity to be able to pursue your goals, the will. And an example of an agency thought would be, I meet the goals I set for myself. And then finally, pathways thinking is the ways to get there. So your ability to kind of construe strategies to be able to reach your goals. And these things are thought to be dynamic. So they kind of interact with one another over time. Maybe a pathway doesn't work, you have to find a new one. Maybe your agency, fluctuates. And so he thought that hope was really a cognitive thing, which I think sometimes we think of it as an emotion, which it can be, but he really posited that this was a cognitively based motivation model of goal attainment. He did a lot of research on hope, and he found that kind of across the board in general samples, greater hope associated with more positive outcomes, greater resilience, greater quality of life, and less negative outcomes, less depression, less anxiety, etc. He also found that hope was generally a trait-based construct, so something dispositional. So I love that Debbie reframed what that doctor had put in her chart about an unfortunate person. No, something unfortunate happened to you, right? That's an example of dispositional versus situational. So Snyder thought that hope was largely a trait-based construct. So you would have the same levels of hope across different situations, like a cancer diagnosis, but that there is some state element. So you might vary and fluctuate a little bit within a kind of set band. All right, so hope versus optimism. I think sometimes we use these words interchangeably, but they are different. So optimism is really the expectation that the future will be good. These two other researchers, Shire and Carver, did a lot of research on optimism. So this is kind of this generalized belief that the glass is half full. And one thing that makes it different is that you have this general belief that things are going to turn out well, kind of independent of what you do personally. That's kind of different from hope, right? This belief that you have a personal ability to kind of move in a positive direction given the realities of a situation. The thing about hope is that it can then exist no matter what the circumstances, which I think is really important. Research does show that these concepts are correlated, but they are empirically distinct, which means they are different. All right, so when we think about hope in lung cancer, and Adam set the stage nicely here, so I will not talk too much about this, but if our goal is to extend survival, there's a lot to be hopeful for, right? So this was an article that came out in 2020 that showed that overall lung cancer mortality was dropping thanks to decreases in smoking and increases in different new treatment availability. I always think looking at the increase in 5-year survival rates for non-small cell lung cancer is so impressive, right? We see that in the last 20 years, that 5-year survival rate has nearly doubled. And I love this caveat that accompanies those rates on the American Cancer Society website that really tells us these numbers don't take into account everything, especially with actionable mutations and things like that, and that these numbers are old, right? So these might actually even be changing right now. There needs to be an updated diagram of this as well. Somebody over there do it. But I think this really nicely shows kind of the huge kind of jolt that we had in new availability of treatments over the last 20 years, particularly with targeted therapies and immunotherapy. So lots to be hopeful for if our goal is to extend survival. So for my dissertation study, which I did about 6-7 years ago now, I was really interested in studying factors that might be associated with positive psychological outcomes in lung cancer. We know a lot about things that are associated with worse outcomes, right? Physical symptom burden, function limitations, uncertainty about the future. But there's not so much looking at what might be associated with better outcomes. And so I was really interested in hope as a positive psychological construct that might help to explain how people cope well in the context of living with lung cancer. And so this is kind of a simplified model of what I was looking at, but now that you all are experts in hope and you know that hope is a goal-based model of motivational attainment, goals are in the middle here. So we wanted to see if hope was associated with goals, and if goals were associated with psychological outcomes, hope was associated with psychological outcomes, and then we did a mediation model to see if we put all this together. So really trying to kind of see in a lung cancer population, did this kind of ring true, like in general patient samples without cancer. And here's a brief overview of the study structure. I'll go into a little more detail here, but we recruited patients. I was at Moffitt Cancer Center for my graduate degree, and so we had people fill out some measures, including Snyder's Hope Theory, and then I did a semi-structured interview with all 75 people, spent a lot of time on the infusion unit, and in these interviews, I asked people, I kind of defined goals, and then I asked people to list all of their goals. Totally open-ended, it could be as many as they wanted, we wrote them down together. And then I asked people to, of that list, pick their top 3 most important goals and rank them in order of importance. And then I had them answer some questions about those goals. So the goal characteristics there. So I asked them about how doable do you think this goal is? How kind of within your control is this goal? And then I asked them some other questions, but I won't talk about those today. So I asked them about kind of if they thought they were going to make progress towards that goal in the short term, in the long term, et cetera. And so all of the patients recruited to this study were living with advanced lung cancer, so stage 3 or 4, and they were receiving first-line treatment at Moffitt. So here's a brief snapshot of the demographics of the sample. You'll see we did recruit non-small cell and small cell. Most patients had stage 4 disease, and patients were on a bunch of different therapies. All right, so here are our findings. So we found that hope was associated with people who were higher in hope, had more meaning and purpose in life, and more positive affect, as we would expect. Hope was not associated with emotional well-being, which was kind of a surprise, and it was not associated with negative affect. Hope was positively associated with perceived goal attainability and control over goals. So if you were more hopeful, you were more likely to think that you could achieve your goals and that you had kind of intrinsic ability to control that. So that aligns with hope theory. And then we also found that those goal characteristics were associated with better psychological well-being. All of these domains popped. So here is a screenshot of the goals. I think this is the most interesting part to me. So we took all of the goals that people cited. There were 344 total, and we coded them into domains. And so we identified 8 core domains that you see listed here. And those 2 columns, you see first the number of patients that had at least one goal that went into that domain. And then you see the total number of goals that fell in that domain. So of the total goals, nearly 3/4 of people had at least one social role or relationship goal. So that had something to do with others, right? Being around family, taking care of family and friends and pets, maintaining relationships. Similarly, almost 3/4 of people had at least one leisure pleasure goal, to go on vacation with my family, right? And then interestingly, the kind of next most common type of goal was everyday practical. I want to keep cooking. I want to be able to mow my lawn, right? All of those kind of everyday things. We did have 2 kind of cancer-focused goal domains. We had palliative outcomes, which was really things focused on kind of comfort and quality of life. And then we also had cancer treatment response or disease outcomes. So those are our domains that are really focused on like cure longevity. So when we looked at what people identified as their most important goal, once again, social role dominated, and you have some examples here. So nearly 1/3 of the sample, a social role goal was the most important thing to them. About 1/4 of the sample, a cancer outcome goal was the most important. So cure, to get rid of cancer, to extend life as long as possible. And then that everyday practical shows up again, which I think is always interesting as the 3rd most common, most important goal. You see a little note here at the bottom that having a cancer-related goal as the most important was negatively associated with emotional well-being, but it was not associated with hope. So what do we make of all that? So I think a lot of this kind of aligns with what hope theory would tell us, right? Hope is associated with how we perceive goals. Hope contributes to positive psychological outcomes. Hope doesn't seem to buffer against negative psychological outcomes, which actually is aligned with theory as well. The idea that you could be a hopeful pessimist, which is kind of counterintuitive, but is true. We know that having valued attainable goals that are within your control is associated with better psychological outcomes, and that having a cancer-related goal as the primary may compromise emotional well-being. And that's likely because a lot of that is outside of our control. So if we're solely focused on that, we might feel really stuck and helpless, right? But as Debbie told us, as her doctor told her, right, you can maintain that as an important goal, but you have to have other things as well, right? And so that's what we find in high hope people, is that they focus their attention on valued attainable goals, even if they maintain, of course, a cancer-related goal is important, but having that breadth of goals seems to be the thing that's really important there. I love this. This was just like in a Healthline article, but I think it summarizes so nicely kind of what this goal literature tells us when we think about quality of life when living with non-small cell lung cancer. And it says, life shouldn't be all about cancer and cancer treatment. Socialize, hang out with friends, spend time on your hobbies, stay as active and involved as you can, continue to do the things that bring you pleasure, which couldn't align better with Debbie's message. We have published some of these findings, so if you are interested, you can always go check them out. So thinking about some practical strategies to kind of foster or maintain hope, there are some hope-based interventions that really just kind of walk through the steps of hope theory, right? They help us to identify and pursue valued attainable goals, focus on goals particularly that are aligned with what's most important to us, our values. So Debbie talked about her grandbaby, right? Like for most people, those values are the things, those are what keep us going. We're not going through cancer treatment because it's fun. We're doing it because we have these broader goals. And then the importance of identifying a range of hopes or goals and strategies to kind of navigate roadblocks, because not every pathway is going to work out, which Debbie also talked about, right? And then finally, a dialectical approach. This is my shtick. So a dialectic is the idea that two things that seem like opposites can both be true at the same time. So two emotions, two thoughts, right? And I think oftentimes we feel compelled to kind of pick one and block out the other, right? We hear people say all the time, you have to think positive, right? But you can think positive and still have a really hard day and feel scared and tired, right? And so a dialectic tells us you can feel both hopeful and scared. You can experience grief for what is lost or a life that looks different than you'd hoped or planned, and feel immense gratitude for what you do have. Here are 2 resources that I really love and I share with patients in my clinic all the time. The first one is the values card sort. So this is a kind of fun activity that helps you to sort your values into piles. And so it has values like adventure,